Following a stroke, typically involving a right parietal lesion, roughly 25% of patients develop unilateral spatial neglect. This is a profound neurological failure to perceive, report, or process stimuli on the affected side of the body. The eye itself is perfectly fine. This is not mechanical blindness or a simple visual field cut. The brain's spatial mapping system has collapsed. This collapse manifests across 3 specific spatial coordinates. The first zone is personal neglect. Clinically, this looks like a patient who only shaves one side of their face, or leaves their affected limb entirely motionless, ignoring their own body midline. The deficit then extends outward into near extrapersonal neglect, the space within reaching distance. Here, a patient might eat only the food on the right half of their plate, or read only the right half of a page, completely unaware the rest exists. Finally, there is far extrapersonal neglect, which corrupts the space beyond arm's length. Patients with this specific deficit will repeatedly bump into door frames on their affected side or misinterpret distant signage, unable to map their broader environment. Compounding these deficits is anosognosia. The lesion physically prevents the brain from recognizing that any of this spatial data is missing. The patient experiences a complete, unbroken reality, even though half of it is gone. Because the patient cannot report a deficit they cannot perceive, standard clinical observation falls short. Measuring this invisible void requires highly specialized functional metrics. Initial neglect assessments frequently default to simple pen and paper tasks. In conventional screens like Albert's test, a patient is handed a sheet of paper and instructed to cross out all the lines they see. A patient with severe neglect will leave the left side entirely blank. But while cancellation tasks confirm visual inattention on a desk, they failed to predict how the patient will navigate a kitchen or cross a street. To capture real-world impairment, clinicians turn to the Catherine-Bergego scale, or CBS, a strictly functional dual-perspective assessment. The first component requires the clinician to observe the patient performing 10 specific daily activities, scoring the severity of neglect from 0 to 3. The second component flips the lens. The patient is given the exact same 10-item scale and asked to rate their own performance. This formula reveals the exact depth of the patient's unawareness. By subtracting the patient's self-reported score from the therapist's observation score, we calculate the anosognosia delta. A high resulting number definitively quantifies severe anosognosia, transforming a subjective behavioral quirk into a hard clinical metric. Establishing this precise functional baseline is a prerequisite. Until you can accurately measure the deficit, you cannot evaluate whether a rehabilitation protocol is actually working. Without dual perspective tools like the CBS capturing real-world function, clinical trials yield skewed data, making it impossible to separate effective therapies from ineffective ones. Once we measure the individual patient, we have to evaluate the vast, conflicting landscape of proposed rehabilitation treatments. Neglect rehabilitation protocols are highly heterogeneous. To isolate true efficacy, research bodies apply strict filters like the modified Sackett scale. The evidence-based review of stroke rehabilitation standardizes its conclusions using the PICO framework, organizing data by population, intervention, comparator, and outcome. In Chapter 13 of the review, this framework is distilled into a strict color-coded matrix to guide clinical decision-making. This table demonstrates the protocol. A red designation means no significant difference between intervention and control. Yellow indicates mixed or conflicting results. A green designation signals clear efficacy, with the majority of studies favoring the intervention. Each color is then paired with a level of evidence marker, like 1A or 1B, denoting the volume and rigorous quality of the randomized controlled trials backing the claim. Sorting the data this way provides immediate clarity, allowing practitioners to discard legacy assumptions and focus purely on data-backed interventions. Applying this systematic filter to standard neglect therapies exposes a severe disconnect between what is traditionally prescribed and what the science actually supports. Let's run the most commonly prescribed therapies through this evidence matrix. Starting with the ineffective category, several long-standing standard approaches fail to hold up under rigorous RCT scrutiny. Both limb activation protocols and general cognitive or perceptual training explicitly lack the evidence required to justify their use for improving neglect. Pharmacological attempts fare no better. Dopaminergic medications and acetylcholine also fall straight into the red tier, showing zero significant benefit for spatial rehabilitation. Moving to the conflicting tier, we find therapies that produce highly variable outcomes across different studies. Visual scanning training and prism adaptation treatment are the primary interventions in this yellow category. The nuance here is translation. While these therapies sometimes improve specific, localized neglect scores on paper, the literature is highly mixed on whether they actually improve a patient's independence in daily life. That leaves the efficacious tier, interventions proven by high-level data to deliver significant functional benefit. For behavioral interventions, visual motor feedback strategies secure a green rating, demonstrating reliable clinical efficacy. But the highest tier proven interventions belong to neuromodulation, starting with transcutaneous electrical nerve stimulation, or TENS. When we look at direct brain stimulation, continuous theta burst stimulation and a nodal TDCS are rigorously backed by high-level randomized controlled trials. The data paints a clear picture. Modern, targeted neuromodulation drastically outperforms legacy cognitive training exercises. The bulk of conventional behavioral therapies simply lacks statistical sufficiency. To drive actual recovery, clinical pathways must pivot away from general training and toward proven visual motor feedback and neurostimulation. Synthesizing this data gives us a modern, evidence-based operational protocol for unilateral spatial neglect. Step 1 is precise mapping. Clinicians must identify exactly how the deficit presents across the personal, near, and far extrapersonal zones. Step 2 is quantification. The invisible deficit of anosognosia must be measured using dual perspective functional tools, like the Catherine-Bergozzo scale. The clinical inertia of relying on simple cancellation tasks or prescribing general cognitive training out of habit has to end. This visual maps the new standard of care. Treatment protocols must be sourced strictly from the highest tier of PICO-validated evidence. TENS, TDCS, and targeted visual motor feedback are the definitive tools proven to drive measurable change in the nervous system. True recovery requires acknowledging that the patient's reality has been entirely rewritten by the right parietal lesion. In modern rehabilitation, we cannot treat what we cannot measure, and we should not prescribe what we cannot statistically prove. By strictly adhering to functional metrics and the rigorous evidence matrix, clinicians can maximize real-world independence for stroke survivors navigating this profound spatial void.